Hey, it's Clint again from Bone Foam. Next we're going to go over our sideline positioner for lateral spine procedures. Just like our legacy positioners and the next end positioner, which we just went over, the sideline is designed to optimize patient positioning for the staff, the patient, and the surgeon. One of the things we're going to focus on in this video is how to really stabilize the patient in the lateral position and also open up the lateral flank where the surgery site is. So the first thing we're going to go over is positioning the base pieces on the table. Similar to the next end, the sideline was designed to fit a pro-axis table as well as a Jackson table. They're going to be some of the more common tables we see. One of the things that can be most confusing of the sideline is where to orient the pieces. So the base piece, which is going to be the leg positioner, they're going to have a lot of different connections at the furthest end of the positioner. That is where we want the feet to be. The middle, we basically want these pieces to meet right over the table break. This is going to be really, really important when it comes to positioning the patient and having the anatomic landmarks in the correct spaces. As far as the orientation of this piece, you'll see that in the middle where the table is going to meet, there is a contour that is a little bit denser foam right here, and that's going to really help with hip support as we go. The very top portion where we want the head, you'll see there's going to be a bit of a kind of a softer cutout there. It's going to be important that these positioners are also strapped down because there's a traction aspect that we're going to go over in a little bit. So this most distal aspect of the torso positioner is going to be where our table strap is. This strap here is our single-use strap that's going to go over basically it's an axillary strap that's just going to go over the patient's chest when in the lateral position, very similar to what they would do with the standard safety belt in the operating room. There also is a table strap connection at the very top that we're going to want to position there. As far as table straps on the leg portion, this distal one, furthest down towards the end where these straps are, this is going to be important that this is secured because when we pull traction, we want to make sure that it's holding down our base piece. Again, we'll get into a little bit more detail in a little bit. The other strap connections are where the hip strap goes. This is a disposable hip strap that'll be pretty vital when it comes to the stabilization of the patient. And we also have a table strap here. The interesting thing about this is we've seen surgeons kind of interchange this. Some surgeons prefer the strap to be a little bit more over the proximal thigh as opposed to truly over the greater trochanter. So if that's the case, these can be switched out. You can move the table strap to here if needed and move the hip strap to here if needed. But largely, the hip strap is going to be the most proximal or the most cephalad on the leg portion itself. Next, we want to show how a draw sheet can help place the hip bolsters. So you can imagine typically there's just going to be a normal sheet covering this whole piece. Next thing we want to do is in this position in relationship to the straps, we want to put a draw sheet perpendicular that will run and hang off the table. What this is going to do is ultimately it's going to help us place our hip bolsters by when this is underneath the patient, it's going to help us lift the patient off the table and not only help lift the patient, but it's also going to help us slide this bolster in. You can imagine if this is trying to slide on itself or on the patient's skin, it's a high friction component. What this is going to do, it's going to help slide those bolsters in between the two. All right, now that we have the positioners where we want them, we then can bring in our patient. Normally, again, they're going to be transferred from this side of the table, not only because the arm board's over there, but also our straps. So when it comes to positioning a patient, we also have to think about why the sideline is beneficial. So positioning this patient, we're eventually going to move them up into the lateral position. The big thing that is really challenging in the lateral position, unlike supine, you're lying on your back, you're not really at risk of rotating or moving so much. When we're in the lateral position, especially depending on people's body habitus, there's just a lot more likelihood that the patient can move. Historically, the patient has been stabilized by, we've discussed it in other videos, rolling up towels and wrapping them in Coban and shoving them in places that can be problematic. And then also, more so for these type of procedures is the amount of tape that they use. We've passed along images and videos of these taping procedures and these tape configuration, and they're quite complex. They help stabilize, but that's where our straps are going to be a little bit more beneficial when it comes to stabilization of the patient and also the ability to redo it. I think with tape we often find if it needs to be redone or you have to do it in a different way, when you pull it off someone's skin, it just isn't going to perform the same way. Again, it can also be problematic and damaging to the table and put adhesives on the table. Things don't slide on the tracks the way they're supposed to. So there's a lot of benefits to using straps instead of tape, which we'll be able to demonstrate in just a second. So once the patient's here, again, we recommend intubated directly on this piece. Anesthesia does their thing. It's time for the ortho team to move in. So now that ortho is ready to go, and we can, ortho or spine, and we can position our patient, the first thing we want to do is find out where this patient's greater trochanter is. So Dawson, he's got quite a long torso here. We're going to move him up just a little bit if we can, Dawson. Right there is perfect. So now we have his greater troch basically lined up right over the table break. That's going to be important because by using this anatomic landmark, it's then going to help position our bolsters where we're really going to optimize the surgical site. So when they're doing a lateral spine procedure, one of the things that they're trying to do is gain access to the lateral aspect of the spine. The challenging part with that is the top of our iliac crest and the bottom of our rib cage is quite close. We're talking just a couple inches of space for them to do a full procedure. So one of the things that they often do is they want to open up. So if I'm doing surgery on my right side here, we need to find a way to get my torso and my legs to have this relationship where I'm basically opening up that side of my rib cage and ultimately the spine as well. This can be done in several ways. It can be done by either, and that's why the sideline is good for both of them because it allows them to do both ways. One of the ways you can do it is actually breaking the table. This is really common using the pro-axis table. And the challenge with that is not a lot of places, specifically with some spine procedures going to ambulatory surgery centers, is a lot of places don't have the resources to have a pro-axis table. So if you're using something a little bit more affordable like a Jackson table or even a standard table, you might not have the ability to really break the table that much. If you can't break the table, what you can do is kind of bump up the hip on a certain side to really help open up that flank. So if we have the greater troch over that table break, we're going to have our spine in a good position. So from here, I like where his legs are. I like where the hips are in relation to the table break. From here is when we're going to move the patient up into the lateral position. This can be done your standard kind of transfer procedure at the hospital. Dawson's going to just help us out though and move up to a lateral position. And then that's the next part is where we're going to put on our shark. But the shark is going to be really important for us for a couple of reasons. Not only is it going to be positioning the arms, but it also is going to really help stabilize the torso of Dawson here. So when we're in the lateral position, one of the biggest challenges, like I talked about, is a lot of Dawson's weight being up in his chest here. It's going to be really pretty unstable. So we need a way to stabilize that. So when positioning the shark base, we want to make sure that the beveled end is positioned immediately adjacent to the torso piece. The next part is we want the shark top to fit in the grooves, and it's going to be really important that the bull nose of the shark is butted up against the patient's chest. We want this to be directly against their anterior deltoid. If it's too far away, we're going to find that the patient is rolling too far and they're not going to be as stable. The nice part about the shark, it has the ability to slide back and forth. So this is going to be important if we want to determine how much rotation we want Dawson to have. It also helps, if the patient's in the middle of the table, we have the ability to slide it more towards the middle of the table, or if they're at the edge of the table, we can certainly slide it the other way. For now, for demonstration purposes, we'll leave it here and we'll strap it right to itself. So now that we have the shark in place, it's doing a couple things. Not only is it stabilizing the torso from preventing sort of rotation right against the anterior deltoid there, but also it's giving anesthesia a lot of access to the down arm and other sort of anesthesia leads. So now that we are in the lateral position, we're then to kind of we're ready to manipulate kind of that spine position that we've been looking for. So in this scenario, we're going to act as if we can't break the table. So what we need to do is you can see how Dawson's spine is kind of going like this, and that makes it hard to access the lateral aspect of that. We need to find a way to kind of open up that space. The top of his iliac crest is here and his bottom rib is here. So we need to find a way to open that up. What we do is we have these specifically designed hip bolsters. You can kind of see where our anterior support or our anterior stability is coming from the shark, and we're going to get some posterior ability from the shape of this bolster. So this is going to be towards the back side of the patient. Typically, at this point, we're going to have to lift the patient. We can demonstrate how that can be done in several ways. Sometimes it's done with a draw sheet. Other times it's just done with several members of the OR. In this case, Dawson's just going to do kind of a lateral plank there and help us out. So now we go down. So basically, you can see where this bolster is. It's going to be basically at the most distal aspect of the torso portion of the base piece. What that does is you can see it kind of acts as a fulcrum where we're now tipping his pelvis this way, where we're starting to open up the space between the top of his iliac crest and the bottom of his ribs. So we really like the way that position is, and that's why that positioning of the greater troch, if we know that if we have this bolster above the level of his greater troch and can land on the most distal aspect of the torso piece, it's going to be in a good position for that lumbar spine. The next thing we have to do anytime you're in the lateral position is prevent or help protect from any sort of brachial plexus type injury. So this is a pretty standard axillary roll, but it just has our kind of support piece on the back of it. So same thing, Dawson's going to help us out a little bit, lifting up. We're going to put this right back underneath. So now we have his torso and his hips in a really good position. We're opening this up. It really feels like we're starting to open up that space. From here, we want to make sure we're positioning the legs appropriately. So oftentimes, these procedures are going to have bony prominences of the knees and ankles hitting each other. Sometimes it's opened up or prevented with a pillow. Unfortunately, pillows tend to lose shape and can shift throughout a surgery. So our dual leg support has the ability to go between the legs and also flex the knees as much as you need. Typically, we're going to have the knees flexed 30 to 60 degrees. So Dawson, you just help me out here. I'm going to put this in right where we bend his legs, and we can get this right where we need to. Ankles are protected, knees are protected. The next part, and maybe the most important part of this system, is going to be our hip strap. So as I said before, a lot of the stability component has always come from the amount of tape that are used in these procedures. Historically, they don't have an apparatus like the shark, so we're getting a lot of stability of the torso from the shark. So once the patient's in the lateral position, we want to show how you can make some micro adjustments using this hip strap. So this hip strap has some grip pads on the inside of it. This is going to help really grab the patient's skin without having a tacky adhesive. Basically, we want the middle grip pad to be right over the greater troch. If that's over the greater troch, we're going to connect it on this side. From here, we kind of want to tighten these simultaneously. If we get them to tighten them simultaneously and we see that he's maybe got a little bit too much posterior rotation, those hips or those grip pads are going to do a really good job of grabbing the skin, where we can make micro adjustments by just tightening the anterior aspect of it. And we're going to help rotate that spine in the anterior direction. If we need to bring them back posterior, again, same thing. We can tighten this side, and it's going to help pull them back this way. The nice thing about these straps, unlike tape, is you can actually tighten, you can make those small micro adjustments using the straps themselves. If you had someone positioned a certain way with tape, you'd have to take the tape down. It then was already against the skin, and tape doesn't naturally perform well under an oily condition or after it's been used before. So I really like where this hip strap is at. He feels very stable here, rock solid up there. The last portion of this is going to be our distal traction straps. Sometimes, not always, a surgeon will actually feel like they need more traction or more manipulation of the skeletal anatomy, meaning they need to find a way to kind of pull the pelvis down this way even more. So historically, as we mentioned, sometimes they'd anchor tape here, pull on it, it would pull on the patient's skin, fail over time. So our straps are ultimately going to go directly to this belt. And we'll kind of show some nuances of this as well. But basically, we want this to be directly on the belt, or the hip strap here, excuse me. And we want one traction strap behind the greater troch, and we're going to put one in front of the greater troch. This is just going to give us the best ability to really manipulate the pelvic anatomy. So I got one behind. The next one I'm going to put in front. Again, you can just kind of release it on the backside, get it to where you need it to be, anchor it down, and then simultaneously, I'm going to adjust his feet a little bit so we're not hitting the perineal nerve and not hitting his ankles. And then you can actually adjust these and pull traction simultaneously to really help pull that pelvic anatomy back down. One thing we want to be cognizant of is not to be putting pressure on the lateral aspect of the knee and avoiding any bony prominences over the ankles. So one of the things we want to show is how these distal traction straps work. If you have a larger frame person, you're going to end up fine because these straps are going to be wide enough where we have enough room to cross these in the middle. One of the challenges what we run into or that you can do is if these are too tight or you have a smaller patient, these are going to be really close to each other. So if we want to cross these, sometimes the end of the strap is going to end right on top of the other strap. And the Velcro is only going to work well if it's, this hook material on the black loop material. Sometimes you might have to put this basically underneath that and then bring this one over the top to have more of that relationship as opposed to having the strap like that and then this traction strap here where it's basically not going to hold as well. So feel confident that it'll be fine putting this down first and then retightening this. Again, one of the benefits of having straps is instead of tape where you can make those adjustments and redo it quite easy. The last part about this is just our axillary strap. This is just a standard safety strap. Oftentimes, this is nice because it not only gives a little stability, but also it's well padded unlike some of the natural or the standard safety belts that you would see. So from at this point, this is the basic setup of the Sideline. Again, the relationship of his greater choke and the table brake is what's going to really help optimize the surgical site on his lateral flank.